Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello, and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. Today, we are answering all of your questions about pregnancy loss, miscarriage, implantation failure, ectopics. These are voicemail questions that you have called and asked. This podcast exists so that you can learn more about your health, your fertility, your body. And I'm so thankful for all of you who are listening and sharing and just helping this podcast grow. You're going to hear some of your own questions in this episode. And if you want to ask your own fertility questions, please feel free to call the podcast at 657-229-3672. Again, that is 657-229-3672 and leave your own voicemail. You can also ask questions on Monday on Instagram at nataliecrawfordmd. Some of those questions will be answered right there on Instagram, here on the podcast, or in the weekly newsletter. And you can sign up for the newsletter at nataliecrawfordmd.com/newsletter. It will have some of my favorite recipes, favorite things, answering fertility questions right there, which a quick read, and you can get a little nugget of information all about your body. A huge thanks to all of you. I know this is a really sensitive topic, so before we just dive in, I just want to say, if you're listening to this and you have infertility, if you've had pregnancy loss or an ectopic, I've been there and I'm just sending a big hug. I know from my own experience, I had 3 pregnancy losses and then I had an ectopic pregnancy before I had my kids. So my kids were my pregnancies 5 and 6. And I know throughout that entire experience, it just brought so much doubt and questions and really made me realize how hard it was sometimes to get the answers that you really wanted, the questions that you had about what could you do, what are you doing that maybe is hurting things, how can you help things, and just what a mind game it is. In addition, of course, to being sad and depressing and just very, very isolating. One piece of advice I just think that's really important. I never told anybody, never talked about what we were going through. And that was definitely the time. Nobody was sharing this type of information. And if I could rewind the clock, the one thing I would say is maybe don't post it all over the internet unless you are sharing your story publicly and you feel comfortable with that. But I think it's really helpful to share with the people who you want to be there and support you if things do go wrong. There's this idea that we shouldn't share our pregnancy with anybody until we're out of the first trimester or out of this gray zone. In case we lose the pregnancy, then we haven't told everybody. But it's so much harder to get support and to allow your friends and family to show up and support you if they have no idea what's going on. So it's going to be easier if you let them in. It doesn't have to be everybody, but I'm sure you've got that best friend or family member or the person that you go to when the world feels like it's crumbling around you. And let that person in. Let them know that you got that positive test and that you're afraid something might go wrong. So not to share it with anybody else, but it's going to be a lot easier to pick up the phone and make the phone call if you do find yourself on the unfortunate side of what happens sometimes when you're trying to get pregnant. Not every pregnancy is going to end in a live-born baby. Not every month that you try will you get pregnant. And I know that can sound silly or like I'm being mean, but there's a lot of attrition or loss in human reproduction. The truth is it takes us a long time to gestate a baby, and there's so many factors that need to be working well. Your body wants to make sure it's giving the best embryo, the best opportunity, and the best environment. So that means your success depends, number one, largely on the embryo. The embryo has to have cells that divide and grow normally, form into organs, but also has to have normal genetics. And genetics can be influenced by how old we are and by the world around us or inflammation and other toxins. So that's not always as straightforward. Similarly, the environment, and this can mean your uterine environment, your body's environment. Your body needs to be able to support a pregnancy. So there are definitely things like chronic disease or illness where your body might be in such a stressed or inflamed state that it may not be able to support a pregnancy, and that might contribute to not getting pregnant. There's also a host of different disease states, autoimmune disease, clotting disorders, uterine birth defects, and other things that can play a role here. So we're putting a lot together in this episode, essentially just talking all about pregnancy loss in general and answering some of the top questions that you guys have. I've been a little under the weather, so I know my voice is a little bit scratchy on this episode, so I apologize and please bear it with me.
Hi, Dr. Crawford. My name is Gemma. I am 22 years old, and earlier this winter, I had a ruptured ectopic pregnancy following the use of a Plan B pill, likely 1 or 2 days after ovulation and then fertilization. So regardless of how it ended up ectopic, I had to have the fallopian tube completely removed, and my period now, about 3 months later, is pretty much back to normal completely. I have 28-day, very regular periods. I was just wondering, now that I've had this experience and going forward want to consider my fertility, what the best next steps are. I'm not sure if I should do hormone testing and have panels of that done, or if I should jump on birth control immediately and preserve potential future fertility. And I was wondering what you would suggest. Thank you.
I'm so sorry for everything you've been through. I know from being on the receiving end of an ectopic pregnancy how hard it is. An ectopic pregnancy is a tubal pregnancy. So if you don't know, that's a fallopian tube implantation of the pregnancy. Now, how does this happen? Egg and sperm normally meet in the fallopian tube. That's actually where fertilization occurs. And then the embryo has to grow and divide over the course of the next 5 to 6 days until it arrives into the uterine cavity, where it is a big enough stage and the appropriate time for implantation. When you have an ectopic pregnancy, this can be random. It can also be due to factors such as endometriosis or any type of tubal disease, history of any sexually transmitted diseases like gonorrhea or chlamydia, having a history of smoking or anything that might change the normal environment of the fallopian tube. So often we don't know why these happen. But the treatment when you have an ectopic pregnancy is typically either taking the tube out or surgery like you had, or having an injection like methotrexate. Now, methotrexate is an injectable medication that's like a chemotherapy, and when you take methotrexate, it stops rapidly dividing cells. The pregnancy is very much rapidly dividing cells, so when it can't take folic acid into the cells, which is a crucial step of cell division, then it's going to stop dividing and hopefully stop the pregnancy from progressing. So methotrexate is one option. Important to know is that you have to follow your hormone levels very carefully. It doesn't always work in one dose. Sometimes you still need surgery, but you need to sit out from trying to get pregnant for 3 months. And that's really important because folic acid is so important in cell division, and without it, you're going to be at a higher risk for birth defects. And you can't overcome the methotrexate by just taking extra folic acid. So it's really important in this circumstance that you take a pause. And when I had my ectopic pregnancy, that's what I did. Just took 3 months off. And I used that time to really cut out a bunch of other inflammatory things in my life and change up my diet and all the toxins we were exposed to. And that actually was the start of setting us up for success when it came to getting pregnant. Now, when you have surgery, we still want to follow your HCG or your pregnancy test down to 0. And the reason why is that we think we got the entire pregnancy, but you always want to make sure. But typically after surgery, this is going to be a much faster drop and a faster resolution. Once your period comes back, which can be anywhere from a couple weeks to 8 weeks after the surgery, just really depending on how high that hormone level was, Typically, that HCG has to drop before your body will start ovulating again. And then after you ovulate, it takes another couple weeks to get to that period. So you've had your surgery, you get to your next period. Now we get to your question, now what? I think it's really important to really take a moment and think about your goals when you've had what feels like such a big step back. On one hand, we've proven that egg and sperm can meet and fertilize. On the other hand, we've not had implantation actually happen. So this is a circumstance where I always like to think if one tube is damaged, which we have to presume that it was, now it's gone, whatever damaged it was the other tube at risk also. So anytime we've had an ectopic, if we're trying to decide what to do next, I always recommend you get an evaluation, which includes your fallopian tube. So that would be an example is like an X-ray test called an HSG or a hysterosalpingogram. To be honest, I tend to like all the data at this point because you are trying, you've had this setback. So that's going to be anatomy, look at your uterus and your remaining tube. Hormones, see how your ovarian reserve is, make sure you're not running out of eggs. Make sure you're ovulating, which by your history, it sounds like you are. And check a semen analysis for your partner to make sure there's no problems there that you need to start working on. Based on that and your goals, we could decide what to do next. Many people will just go back and try naturally longer, and that might be appropriate depending on the testing, your age, and how many kids you want. It's also not uncommon to want to expedite care, to say, well, maybe it took me a little longer to get pregnant with that, or because I went through that, I want to try something different. Ultimately, the treatment for tubal factor is IVF. So sometimes IVF is the next indicated step, depending on the full picture. So in short, I would recommend considering getting an evaluation and then going from there.
Hi, Dr. Crawford. My name is Kate, and I had a question about miscarriage. I just had a miscarriage at 10 weeks, though it looks like the baby had stopped growing around 8.5 weeks. I did have a D&C. That was about a week ago exactly. And today I noticed a lot of symptoms of ovulation. And I took an ovulation test and it did say I was ovulating, but I know that HCG can still be in your system and interfere with a test like that. But with egg white cervical mucus, higher libido, some of the other ovulation symptoms I normally get, with those present, is it possible to have already ovulated only 1 week post D&C? Just curious about how that works and sort of how cycles vary once after a miscarriage. Thank you for everything and hope to get this question answered. Thanks. Bye.
I'm so sorry for your pregnancy loss and for everything you've been through, the D&C. I've been there. The whole thing is not fun. So huge, huge hug and lots of love and lots of thoughts. The short answer to the question is that typically no. When you have a pregnancy that makes it to about 8 weeks, typically your HCG is very high. And even if that pregnancy stops developing, it's still inside. If you haven't started to have the miscarriage, the placenta is still attached, and there's still HCG in your body at a really high level. That HCG is going to prevent your body from starting to recruit a new egg, a new follicle. And if we think of the normal timeline of things, that HCG has to drop down lower. It doesn't actually have to be all the way 0 to start growing another egg, but it definitely has to be dropping and getting under a threshold. And then the brain will sense this drop and will send out FSH to start to recruit another egg. From the time FSH is sent out, it takes about 2 weeks to get to that ovulation stage, that peak fertility, high estrogen, egg white, cervical mucus, all of that. Now, theoretically, can this happen a week after a D&C? Maybe, but typically a D&C that I would say would be at a much earlier stage. At 8 weeks, if they saw an 8-week baby, that's going to be quite advanced, and I would think it's extremely unlikely, even with a D&C, you get everything out, your hormone level's not going to drop rapidly enough to have that ovulation 1 week after that. More realistically, what do I think happened? Probably yes, HCG can bind to the LH receptor. They share a receptor, and so it can cause those LH tests or those ovulation tests to flag positive. Also, after the pregnancy is failing, as HCG is dropping, the placenta was removed right around the time when the corpus luteum was going to die, and there was no placenta to take over. You're going to have this pretty profound drop of progesterone after the DNC, which might make some of the high estrogen symptoms from the pregnancy just more present because now you don't have progesterone countering them. So things like having that sex drive, the cervical mucus might still be present from the estrogen dropping, just progesterone dropped faster first because of the timing of how far along you were. This is typically why we say, hey, let your body recover, have a period, and then start trying again. But theoretically, you will ovulate sometime before that next period. And we don't always know when it is because the body is crazy. And you may have had your HCG even higher and started to drop from when the pregnancy got at its peak to when you had the DNC. So certainly some people could ovulate a week after, but I would expect in this case that's less likely what had happened. And the last thing here is this is often why after a DNC it might take you much longer to get to that next cycle than you expect, because it might take 2 or 3 weeks for that HCG to get down. Then you have to grow an egg to ovulate, so that's a couple weeks later. Then after ovulation, have a couple more weeks. So having 6 to 8 weeks before your next period is not that unusual. All right, I'm going to keep answering some of your fertility questions, but a quick reminder, you can call and leave your question at 657-229-3672.
Hi, Dr. Crawford. I'm removing my IUD soon, and I'm worried about a potentially thin uterine lining. After removing my IUD, should I wait to try to conceive to lower risk of miscarriage? I'm 31 and I want to start ASAP, but I'd rather wait a month or two than miscarry if waiting can make a difference. I've been on hormonal birth control for about 16 years, about 9 on the pill, then 7 on the Kyrena, then Mirena. Before my IUDs, I had heavy, long periods. After my first IUD, I had no periods, then light periods. Those have continued with my Mirena. They're every 25 to 27 days, last 6 to 9. Most of that is spotting with a couple days of red blood. I tested with OPKs while on my IUD for 4 cycles and only got 1 or higher on my TC ratio once. Also, I had 2 colposcopies in a week to remove precancerous cells from HPV all over 2 years ago. I did get a pap smear with normal results since then. Should I wait after removing my Mirena? And if so, how long? I wish I found your podcast and YouTube sooner. They are fantastic. Thank you for all you do.
Thank you so much for those sweet words. That was really kind. And I love this question because you're trying to be proactive. I am worried after having prolonged hormonal contraception with progesterone, so specifically daily use of the birth control pill, the combined pill without ever taking the placebo pills or having a break, and progesterone IUDs like Mirena, Kyrena. But I'm much more concerned in people who have amenorrhea on the IUD. So the patient I saw this past week who was on her second IUD and hasn't had a period in over 10 years, I'm a lot more worried about her uterine lining than I am in this circumstance where we are still having a period monthly. And yes, it might be lighter, but it's not non-existent. In people who are having no period, I recommend getting the IUD out about 6 months before you want to get pregnant. That's just going to give you time to observe and see if you have a cycle come back, if it's regular, and allow you to get in so that we can evaluate this. Now, in this circumstance where we're already having periods, I actually do believe you're ovulating. It's probably just hard to detect some of these hormonal changes because remember, you have a long-acting progesterone device in your body. So if your hormonal detection system's trying to look at a ratio change, that might be thrown off by what you're using. The fact that you're having regular cyclic bleeding means that it's highly improbable anything else is causing that except for ovulating. Progesterone implants or IUDs, they have a daily progesterone release. So you are having progesterone in your body every day, but it's not at a high enough level to prevent ovulation all of the time. And some people it does, and some people it doesn't. So even some women who may have no period may still be ovulating. They may just not have a period because of that progesterone impact on the uterus itself. So if you have an IUD in place, the progesterone impact on the uterus is not so profound to totally thin out your lining and you're still having a bleed. I am much less worried that you're going to have a problem with a thin lining. I would say remove the IUD, give your body maybe 1 month and get a normal cycle before you start trying. I would expect that over time your periods will probably get a little bit heavier, but I would not hold off on trying to get pregnant if you're wanting to, especially in the context of having regular cycles, even if they're light while the IUD is in place. There's no increased risk of miscarriage.
Hi, Dr. Crawford. Thanks for doing all of this. I always learn a lot from your podcast. So I'm 39 years old. I had 2 miscarriages this year and 1 chemical, all in 2024. With a fertility clinic, and I feel like I've been tested for a ton of stuff. So I've been tested, for lupus, anticoagulation, antiphospholipid, non-celiac gluten intolerance, karyotyping. My partner had a semen analysis. I've had sonohistograms. My AMH is 7.1, which in the lab I'm using, it's picomole per liter, and it's slightly lower, but it should still have a 7. It was the lower limit of normal for cutoff for a predicted normal IVF response. So my questions are, what was suggested to me was a antagonist protocol with estrase priming prior to starting my cycle. So a few of my friends who've done IVF haven't had that, so I'm just sort of wondering in what context that is used. And also, while discussing it, they did suggest that PGT testing didn't really show a benefit in recurrent pregnancy loss, but I found that really surprising. And our IVF physician, she believed that there was a benefit there, so we would like to pursue it, but of course that adds to the cost. So I'm just sort of wondering your opinion and mostly about the antagonist protocol with estrase priming. Thank you so much.
Anytime we're having pregnancy loss, especially recurrent pregnancy loss, it can be really, really tough. So big hugs. Sounds like the appropriate first workup is done, which in general, if you've had multiple miscarriages, we want to check for autoimmune disease, specifically autoimmune thyroid disease. You want to check for diabetes. You want to check for clotting disorders like antiphospholipid antibody syndrome. You want to check karyotype for both male and female. And then I always recommend, the other parts of the fertility evaluation: uterus, fallopian tubes, sperm. Now, the confounding factor here is our age, right? Being 39, because we know that miscarriage occurs at a much higher frequency as we get older. And some people have more genetically abnormal eggs than others. So in short, a few things here. One, it sounds like the appropriate workup for RPL has been done. Very often, we do not find a cause. And I always tell patients, we're doing all this tests. There's probably a 15% chance you're going to find one of these things that caused our pregnancy loss. The other time, we're kind of left in this unexplained, or it's genetics or age or some combination. So when it comes to what do you do next? The IVF protocol. Remember that the IVF protocol's goal is to try to get as many eggs as possible. Now, when we try to get as many eggs as possible, that's going to be a dependent factor on your age, your antral follicle count, your AMH. In your age range, we would say that most people would be having a lower antral follicle count just based on age. And so antagonist protocols are one that is typically used for somebody who might be either a higher responder. So if you have a high egg count, we're definitely usually leaning at an antag first. Or if you're oversuppressed on some other options, sometimes the protocol you're mentioning which is an estrogen primed antagonist, is one that we come back and we use for low responders. So very high or very low. When it comes to kind of middle of the road or slightly older or recurrent pregnancy loss, I use a lot of Lupron protocols, but what you're going to find is a lot of clinics have a lot of different preferences. And in truth, you want two things. You want your doctor managing a protocol they feel comfortable with, number one. Number two, you want to feel like they are personalizing the protocol to you. So why are you choosing this protocol for me? What other protocols could we use? What will we do if we don't like the response to it? There are clinics who just use the same protocol in every patient. It makes it easier for their staff, easier for their nursing team, easier to manage. It is less good for all of the patients. It's fine for the majority of the patients. But there will be people who will not have the response they could have if we had personalized a protocol. And if a clinic is going to do this, just apply the same protocol to everybody, it typically is an antagonist protocol. So anytime I see somebody who's older with an antag being the first line protocol, I always just want to think why. It might be the very appropriate thing. They may say, I saw a ton of eggs on your antral follicle count. I want to make sure I'm able to really stimulate you hard and get as many eggs as possible. And since you're older and you've had pregnancy loss, we need that. Very reasonable thought. But that's my one red flag, is making sure that it is personalized to you. I'm a big believer in PGT, or pre-implantation genetic testing for pregnancy loss, especially as we start getting older or we've had testing that's normal. So you have pregnancy loss for a reason I do not know why, and I have a test that can tell me which of the embryos are more likely to have a higher implantation rate. I'll say that the studies looking at live birth and improvement in pregnancy rates for recurrent pregnancy loss patients using PGT have some structural flaws. And in general, if we have a reason to believe you're going to have half or more than half of your embryos genetically abnormal, which we do based on your age and your pregnancy loss history, I think that understanding which embryos are genetically normal is going to be a hugely beneficial factor in helping you get to that live birth.
Hi, Dr. Natalie. I'm so excited about leaving this voicemail. I'm an avid listener to your podcast, and thank you for all the work that you do for us struggling with infertility. So my question is, my husband and I have done 3 transfers for IVF, and we've had 3 complete implantation failures. So no chemical, no miscarriage, and we're wondering what we should do next. I know previously it's been discussed about doing ERA, but I know that the research isn't really backing ERA anymore. So I'm wondering if there's something else we should be doing. We have done all the necessary tests that were part of our pre-IVF panel, so doing a sonograph, looking for any polyps and things like that within my uterus, and everything looks great. My husband does have some male factor infertility, so that's why we've gone the IVF route. Prior to IVF, we did have 1 miscarriage, and I miscarried about 10 weeks. And within that, we were able to get pregnant when we started trying fairly quickly. So when we didn't get pregnant again, we wanted to be aggressive as possible and did IVF. And now we are sort of confused, especially when we were able to get pregnant before, why IVF is not working for us. We have 4 embryos left. We had 7 in total after PGT testing. So yeah, we're hoping to get some answers. So thanks so much, Dr. Natalie, and we hope to hear the answer for our question soon.
This can be so frustrating, especially after you've had a natural pregnancy and then a loss, and then now you can't even seem to get positive pregnancy tests. When it comes to recurrent implantation failure, so I define that as 3 transfers with euploid embryos that have not had a positive pregnancy test or have not made it to a clinical pregnancy. So we're definitely in that category. There's a few things that I'm thinking about. So I typically want to think through the protocols that have been done. Have these all been the exact same type? Are they natural transfers, modified natural? Are they medicated cycles with estrogen? Are they medicated cycles With Lupron, are they longer protocols, a 2-month Lupron suppression, or Lupron and letrozole? So there's a lot of variety right there in the different types of protocols. Were there any concerns? Was your lining thin at all during any timeline? Have they tested you for any thyroid disease, thyroid antibodies, for diabetes, for clotting disorder? A little bit of the recurrent pregnancy loss labs I typically bring over into my implantation failure, but not everybody does that. In general, I tend to think of this as likely something to do with environment, so I want to make sure we're changing up the environment. Bad luck once or twice can be the embryo, but if we're having this over and over, how can I change the environment? Should I do a hysteroscopy? Go take a look with my eyeballs. It's just a better test than a saline sonogram. What have these past protocols been? The more failure I'm having, then looking more at doing cycles with Lupron so that I can suppress the immune system and decrease inflammation, suppress any possible endometriosis or adenomyosis that might be playing a role. My standard kind of controlled medicated protocol typically is about 30 days of Lupron. But when we get into the recurrent implantation failure zone, I really love to do the 2-month suppression of Lupron and letrozole first. And with that, I usually do like to do a hysteroscopy so that I can just look with my eyeballs instead of trusting the saline sonogram. I'm not opposed to an ERA, and maybe you've tried these other protocols and that is the appropriate next step, but it has fallen out of favor, and seeing more and more people get pregnant without having to do that makes me lean on it even less. Also, think through if you have any known autoimmune disease. Do you have any signs or symptoms of endo? Make sure your doctor knows about that because that might play a role in your protocol. I also tend to throw on some things like antibiotics, baby aspirin, steroids. These all have limited evidence, but no evidence of harm. And so I don't throw them on right away, but these are circumstances when we're having recurrent implantation failure that I'm thinking about them. And then sometimes blood thinner like Lovenox really depends on the cumulative picture, and typically not until I've really run through all of my different transfer protocol options. So I guess in short, I would say really make sure you think through your own medical history and symptomology and talk to your doctor about that. Think through the protocols that you've done to grow the lining, and have they all been the exact same? How can you change those? What can you do to change environment? And make sure if there's any other medical problems. I've had patients lose weight, go on GLP-1s, decrease their inflammation by losing a bunch of weight if they were overweight. I've had patients, get a hemoglobin A1C checked and find out they have diabetes or find out they have thyroid disease. And changing those diseases and getting them in check also changes the environment. So really take a global approach here. Control the factors you can when it comes to your lifestyle, environment, inflammation, but really think hard about the protocols and what you've been doing and what changes maybe there could be. I know recurrent implantation failure with genetically normal embryos is one of the really hard things. It's just a mind game because we think genetic normalcy must work, but the truth is that it doesn't. We look at a 60 to 65% chance of success per embryo, so we know not every embryo is going to work. Some people are just going to fall on the bad side of the odds, but we always want to make sure we're looking at your circumstance and personalizing and making changes where we can to control all the variables that possibly could be playing a role. Wishing you all the best. I hope you guys learned some in this episode talking about pregnancy loss in general. And if you have questions, please feel free to call the voicemail at 657-229-3672. You also can leave your questions on Instagram on Monday at nataliecrawfordmd and check out the YouTube channel at nataliecrawfordmd. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.